morning, good afternoon, good evening, everyone. Welcome to this very, very interesting session, and I'm sure you will enjoy it because we really have great experts talking to us, and also important is it's something which is new and which is very effective. So you will be hearing from three speakers. Justice Hoffmeyer, I'll introduce all of them at once and then we'll jump in straight. Justice Hoffmeyer will be talking about the suction tube uterine tamponade, and Justice, in fact, needs no introduction, and if I am to really introduce him, it will go on for a long time. But just in brief, Justice is a professor, obstetrics and gynecology department, University of Botswana, and advisory director, Effective Care Unit, South Africa. His research interests are innovations, randomized trials, and Cochrane systematic reviews relevant to maternal health in low-resource settings. Innovations included, which is very interesting, is in the context of PPHs, titrated oral misoprostol solution for labor induction. So that was one of them. The first randomized trials of delayed cord clamping for preterm birth, and misoprostol for postpartum hemorrhage, and posterior axillar sling traction for shoulder dystocia. The other experts I will be introducing is Andy. He's the Vice President of Research and Development and Manufacturing at Alidia, have I pronounced it right? Health, where he leads development of the JADA system for vacuum-induced postpartum hemorrhage control. The device is currently under review at the FDA, and after recently completed pivotal study, Andy and his team are also developing a low-cost version of the JADA system for low-resource setting. And our next speaker will be Marcella. She's an assistant professor in the University of Utah, Department of Obstetrics and Gynecology. She's a maternal fetal medicine specialist and a dual boarded in addiction medicine. That's so interesting, something so different. She's a medical director of OB AirMed team, a dedicated maternal transport team. Her research and clinical interests include understanding causes of preventable maternal mortality and improvement of maternal transports to achieve this goal. The floor is to all of you.
Thank you very much. So I will share my screen. And are we live? Yes, all right.
We just need the full.
Yep, here we go. Full Monty, Justice.
And hello, everyone. Thank you for this opportunity to speak for 5 minutes about suction tube uterine tamponade. I'm speaking on behalf of my colleagues at Effective Care Research Unit, Mandisa Singata Madliki and Joanne Batty. I've no conflict of interest in suction tube uterine tamponade or balloon tamponade, but will briefly mention the safe birth tray, in which I do have a vested interest. Because postpartum hemorrhage is usually self-limiting, the only way we can be sure that our interventions are contributing to a good outcome is through randomized clinical trials. For refractory postpartum hemorrhage, inflating a balloon in a bleeding uterus is an intuitively attractive procedure, and we know that in more than 80% of cases, the bleeding stops. What we don't yet know for sure is whether outcomes without uterine balloon tamponade would be better or worse. In South Africa, we developed a free flow balloon tamponade system with an improvised surgical glove balloon, which allows uterine contraction while maintaining consistent pressures. This method is now available as the Ilavi system and may be more physiological than the fixed balloon that are usually used, the fixed volume balloons that are usually used. Another attractive option is using suction to contract the uterus, promoting physiological hemostasis. And I'd like to suggest the theory that both the balloon and suction may also stimulate release of uterine stimulants from the lower uterine segment. 100% effectiveness has been reported both for the stainless steel suction tamponade cannula, which you can see at the bottom of this slide, and for the InPress device, which is now called the JADA system, which will be presented shortly. So we know that both balloons and suction devices are associated with arrest of hemorrhage in most cases in which they are used, but randomized trials are still needed to confirm whether this association is causal. If suction tamponade is found to be effective, the question arises as to how it could be implemented globally. Postpartum hemorrhage can occur anywhere at any time. When purpose-designed devices are not available, we'll need to improvise, as we've done with the condom balloon tamponade. For this reason, we've assessed the functionality of a very inexpensive and widely available device, the Levin stomach tube, as a uterine suction device. And this paper in which we reported this study actually won the FIGO Journal's prize for the best LMIC paper in 2019. We've also reported 3 cases in which we've used suction tube uterine tamponade as a last resort in catastrophic postpartum hemorrhage. In all 3 cases, the bleeding stopped when we applied the suction, though we cannot be sure that this was due to the suction tube tamponade, as we didn't have a control group. We use a 24 to 36 French gauge Levin tube, and it can be attached to any suction source, wall or electrical suction. And during transfer, we've used a manual vacuum aspiration syringe to maintain the suction. Our other innovation in postpartum hemorrhage is the safe birth tray, which is placed against the mother's buttocks after birth and enables midwives to quickly diagnose postpartum hemorrhage when the first chamber, which holds 500 mils, overflows. This is similar in principle to the disposable plastic drape described by Suellen Miller yesterday, but it's a non-disposable device. So in conclusion of my part of the talk, if suction proves to be an effective method of uterine tamponade, the Levin stomach tube may be a useful improvisation when purpose-designed devices are not available. We're currently comparing suction tube uterine tamponade with the current WHO standard of care, which is uterine balloon tamponade, in a pilot randomized trial at 10 South African sites. So thank you for listening to my part, and over to Andy and Marcella.
Thank you very much. So thanks for joining us for the second breakout session. On behalf of myself and Andy, we're going to present the vacuum-induced hemorrhage control. These are our disclosures. I was the site PI at the University of Utah. I didn't get any personal compensation, but the University of Utah was supported by Alydia Health, and Andy is an employee of Alydia Health. So the JADA device, or the predecessor to the JADA device, was first introduced in this paper. It's that was published in the Green Journal. It was conducted in India. 10 women participated and received the vacuum-induced hemorrhage control device. There was cessation of postpartum hemorrhage within 2 minutes for 100% of the participants without recurrence, and there were no related adverse events reported in this case series. And the senior author on this paper is Dr. Segnitz, and he is the medical advisor at Alydia Health. Andy, would you describe the JADA system for us?
Very sure, thank you. Yes, I'll describe the JADA system and then go briefly into some of the new innovations that we're working on at Alydia Health. So the JADA system is an all-silicone construction. Next, please. Upon insertion into the body, we inflate that cervical seal up to about 5.5 centimeters with 60 cc's of saline to create a seal so that we can get a vacuum produced throughout the entire uterine cavity. The vacuum we use is a very low-level vacuum of 80 millimeters of mercury. Next slide, please. And as that vacuum is applied, the uterus collapses down onto the device. And you can notice at the back end of the tube there is clear, so we can actually see the blood and fluids flowing out of the uterus, and as the uterus collapses and starts contracting down onto the device. Next slide, please. We're also working on a low-cost design. This is designed for lower resource settings, or actually just anywhere where cost is an issue. And we don't expect to give up any main performance characteristics of the device. It's explicitly designed to be the same, but we're doing that through fewer components and a new cervical seal that does not require inflation with fluid. And then the distal tip of it is still designed, just as the JADA system is, to be able to maintain vacuum in the presence of collapsing tissue and clotted blood. And if you could break away just a second from the video here to show the same performance as the JADA system with that device. Thank you.
Okay. So I'm going to take a moment to describe the Pearl study, which was a trial that completed at 15 sites. The PI was Dr. Mary Jalton at Columbia. I was the PI at the University of Utah. Over 16,000 women were screened at these 15 sites. 7,000 were consented, and 107 were enrolled and actually received the device. At Utah, we had 16 cases with 17 individual investigators who used and evaluated the JADA system. So this study is both under FDA approval for the system, as well as the paper describing our results is under review at this time. Just briefly, this was a prospective single-arm literature-controlled pivotal clinical trial. Our primary effectiveness endpoint was control of postpartum hemorrhage with no non-surgical second-line or other surgical interventions to control uterine hemorrhage after the JADA system was placed. And the primary safety endpoint was incidence, severity, and seriousness of device-related adverse events. Women could participate depending on site with either vaginal deliveries or C-sections. Their postpartum hemorrhage needed to be related to atony and had failed uterine tonics and massage. And as I mentioned, 107 women were enrolled, and 96% of those women completed a 6-week follow-up. Want to describe a little bit of our experience at the University of Utah. So the 17 investigators included a mix of both residents and attendings. The impressions, this is me learning how to place the device with Amy, one of the scientists that was working at Alydia. Our experience is that 100% of our investigators describe the device as fast in controlling the hemorrhage, and 94% in ease of placement. So we've had a fantastic experience with the device and are excited to move this forward. On a personal note, I've worked both in Mexico and in Zambia, and I'm the medical director of OB transport, and folks don't necessarily think of low resource centers in the US, but here in the Intermountain West, we have many, many, many centers where really blood is either not available at all or very, very limited amounts. And so we are excited to investigate how the development of this device may change our practices here as well. Thanks for listening, and we are happy to take any questions.
Thank you so much, all of you, for this excellent presentation. I think the floor is now open for questions. Can you please type your questions in the chat, in the Q&A box? This is from Debbie. Can you please share the cost with us?
Andy.
Andy.
I presume you're talking about the low-cost device. Yeah, we're not at a point right now where we can actually discuss the cost. It's clearly made to be a much lower cost version of the current design, and I'm happy to be at that point. But I think at this point we're unable to quote what it will eventually cost. I appreciate the question.
Yeah, Andy, I think where people are getting at, because we have a similar question from James. What he meant, I mean, like there are the two things, the JADA system and the low cost alternative. So that's where that's the other thing they want to also know.
Sure. On the JADA system, equally, we have some ideas on the pricing, but we're actually just pre-approval. And so at this point, the commercial team is trying to figure out, where the actual price, makes sense for the JADA system. That'll clearly be for the United States at this point. Again, we just don't share that number just yet because we have not started our commercialization. But clearly you can look at the complexity of that device and the number of parts on there, and you can see that the lower cost would be much lower than that. That's the goal, is to bring the cost down on that lower cost system. But as Dr. Hoffmeyer pointed out in his presentation, this is a purpose-built device. There's no way around that. There's certain features of it that we believe are essential for the therapy to be consistently applicable, especially in the immediate postpartum domain, where the vaginal canal and the cervix can be quite loose. And so, you know, there's places for these types of devices. And in this case, Lydia has chosen to go to more of a purpose-built design. And, you know, unfortunately, are unable to share the target price at this point.
Okay, thank you so much.
Sure.
While we're waiting for people to type in their questions, I think it would be worth responding to the question we had earlier on regarding the risk of uterine perforation with the collapsing uterus and how placement is affected by that, for this group to be really aware of.
Dr.
Andy,
Hoffmeyer, would you like to start that?
Okay,
or do you want
I'll take that one. Thank you very
to
much.
hear from you?
That question came up before, and the only device where I think perforation could be a possibility would be the stainless steel device, which was developed by Drs. Raman Panikkar in India, because that's a rigid device. But as has been mentioned, the Jada device is a soft silicone device, and the Levine tube, which we've used as an improvisation for this purpose, is a very soft plastic catheter. It's not even as rigid, it's not at all as rigid as a plastic manual vacuum aspiration catheter, which is used for uterine evacuation, where the principle actually is very similar in that when one's doing a uterine evacuation, it's been well shown that if you use a vacuum device such as the MVA catheter, there's much less bleeding. The uterus collapses down and stops bleeding. But those manual vacuum aspiration catheters are fairly rigid. The Levine tube is quite different. It's a soft plastic tube. It has no rigidity to it. So if one were to keep feeding it into the uterus, it would simply curl around. It wouldn't keep going in one direction. So I think the possibility of perforation with the soft Levine tube, or as I understand it, the Jada device, which is a soft silicone device, is really not a real consideration.
Thank you, Justice. We have a very interesting question from Debbie. Debbie asks, do you have much problem with clots blocking the suction?
No. At least in our experience, I can just speak for the Utah experience, we did not have that experience at all.
Was there any specific reason for that? And this is my question. I'm adding on to that, what Debbie mentioned. Was there any specific reason? Because, I mean, as the uterus contracts and the blood starts clotting, if it's not a massive PPH, wouldn't you expect?
Mm-hmm.
So I at least in our experience, and perhaps Andy can, but in my experience, when the suction device, it's not, unlike sort of the way we think about uterine tamponade, that sometimes there's blood that's building up in the back of the balloon, because the uterus is completely clamped down, then there's constant suction on the uterus. There isn't blood that's being built up. It's just simply not there. So you don't have blood that's sitting in the tube and clotting. It's just, it has been sucked away, and you'll see maybe small amounts, but really there's not, there aren't huge clots that are sitting in the tube because that has all been put into the canister. Andy or Justice?
Right. So, yeah, so I think the idea here is that, first of all, the design of those vacuum pores that we refer to, they're large enough that they will suck in small pieces of clot. Mm-hmm. And that green shield over the top is actually designed to keep larger pieces off of those holes so they do not clog. So we've purposely built some features into the tip of this device and also low-cost design to be able to be resistant to that. And in fact, one of our tests in the lab on the R&D side is we actually take clotted blood and challenge the device with that in a uterine model that we have. The other piece that is important that Dr. Smith referred to is that when this device is placed, if the bleeding has been discovered after a long period of time, they'll do a sweep to get out any clot that's in the uterus, because that is known to obviously keep the uterus from collapsing down in the first place. So once you do that, if you put the device in, you have mostly blood that is in the liquid state or non-clotted state. And so the propensity for large clots to be in that condition is low. And so that's why we just didn't see it in the study as an issue.
I think,
shall I also come in? Thank you, Debbie,
yeah, please,
for that.
just
Nice to know you're in the room. With the Levine tube, the ports are quite large in relation to the diameter of the tube, and they have a radial arrangement around the tube, so that there are 4 ports which will always be directed in 4 different directions. And obviously it's not impossible for blockage to occur, but what I can say is that we did a proof of concept study in 45 women at cesarean section, where the tube was placed at cesarean section and suction applied. And in all 45, well, in none of those cases was there blockage. Throughout, we left the tube in while we completed the cesarean section, we applied the suction. And at the end of the procedure, we checked that, and every tube was still patent, every tube was still sucking. And the other interesting thing was that there was no, even though many of these women had cesarean sections in labor with a widely dilated cervix, when suction was applied, all the tissues, both the uterus, cervix, and vagina, collapsed down on the tube and formed a seal. So in none of the 45 cases was there any leakage. We monitored carefully for that. And in all 45 cases, shall we say, the soft tissues of the birth canal collapsed in and sealed on the tube. And in all 45 cases, the ports remained patent. There was no blockage. But I don't think one can say it would never happen.
thank you. And a very important question from Stephanie. Do you have any data information on reported pain levels among women on whom the device was used? I think this is important regarding the pain level of the woman on whom the device. I think it would be for both the devices, if we can.
Dr. Smith, would you mind?
So certainly in the both in the original case series that was published in the Green in 2016, 100% of the women tolerated the procedure and the placement. And in our experience in Utah, similarly, 100% tolerated the procedure. In my personal opinion, and we're still waiting for the trial to be published. But I think that this is actually better tolerated than the uterine tamponade balloon.
Justice?
We don't have data on that with the Levine tube because the 45 cases at cesarean section were all under spinal analgesia, so there was no sensation. And the 3 cases of postpartum hemorrhage after vaginal delivery were in women who were quite severely collapsed and in fact obtunded. So there was no way of really asking them or assessing the level of pain. But the current study that we're doing, where we're comparing suction tamponade with balloon tamponade, in the first 20 women, of whom 10 will, well, half of them, it's randomized, it may not be 10 exactly, half will receive balloon and half will receive the suction tamponade. We are asking carefully about their experience of pain, and we'll then actually be able to compare the balloon with the suction tamponade in terms of comfort and tolerability and pain for the women. But we don't have that information yet.
So Justice, when do you think that the results would be available?
We had hoped this trial would be completed within about 18 months. We have been slowed, I must say, by the COVID pandemic. Unfortunately, our doctors are working under dreadful conditions at the moment. And so We've recruited only 6 out of the 84 women into that trial, and the last month or two we've only had 1 recruitment, and I think it's largely because people have so many other things on their mind. So I anticipate we won't have results for perhaps another 18 months from now from that trial, although we'll have preliminary results. We have our pilot phase in which we have in-depth assessment of the women's perceptions and the providers' perceptions, which will be the first 20 cases. We hope by early next year to have results on that.
Thank you. And now, Justice, this is for you. From Anders, what he mentions is, because I think with the JADA system, you had the cervical seal. He's asking, what causes the cervical seal when using the live-in device, the tube?
Yes. This is a very common question, and I've had many discussions with Andy about this. The interesting thing about suction, negative pressure compared with positive pressure. I mean, anyone who's done plumbing with plastic piping will know that positive pressure tends to push joints apart, whereas negative pressure tends to suck everything together. And because the tissues of the birth canal from the uterus, and particularly the cervix and the vagina, are very soft, compliant tissues, when there is negative pressure on a circular thing such as a single tube, those tissues simply can collapse onto it. And all I can say is that in the 45 cases at cesarean section, as I said, of which many were women with dilated cervices, there was never a leakage. Once the suction was applied, the soft tissues collapsed onto the tube and formed a natural seal without there being any specific sealing point. It was simply a seal onto the round tube.
I think, thank you, Justice. And that reminds me of the question to Andy, which was raised by our in the previous group regarding that the os being wide open, how would that seal fit in? So I think, Andy, it would be good for this group to hear about this. And there's one more question so that you all can answer. Was this suction device, the JADA system, found to be effective in PPH due to atony? This is from James. So there are 2 questions. Sure. Respond to both.
Sure. The second one is easy. That was the purpose of the JADA study. The Pearl study was to study PPH in cases with atony. So that was with atony in those cases. That's a specific idea there. Yeah, regarding the seal, it is a great question. I smiled as that question came across because Dr. Hoffmeyer and I have spoken about this much. I think the way we view this problem set is that we use a very low level of vacuum. Obviously, Dr. Paniker was using, maybe that's not obvious, he was using a very high level of vacuum where we think the tissue was sucking onto the suction holes themselves. And I had mentioned in the previous session that our intent is to not allow the tissue to suck onto the vacuum pores and instead maintain this vacuum throughout the entire uterine cavity during treatment. And we feel the best way to do that is to not rely on the tissue to actually come down onto the device as a result of the suction and suck onto the device, but to provide a seal with that low level vacuum. Where I think this is going to be important is as we start looking at the vacuum systems, another part of physics and kind of just playing around with maybe plumbing in your house is knowing that the more of a leak that you have, the larger volume pump that you need on the vacuum side. So we also think that the seal provides kind of a sure condition in the relatively dilated postpartum cervix to be able to get a good enough seal that a low level vacuum can be immediately effective in a large number of patients. Now, I'm not speaking from a data standpoint, but I'm just speaking from the concept behind why we have that seal in place. So certainly Dr. Hoffmeyer's had some great success without it. I just think that we're viewing the seal as something that assures that success happens at a very, very high reliability rate. And we'll have to see how it turns out, whether it can be completely done without the seal.
You've hit on the controversies in vacuum-induced hemorrhage control.
Yeah. So I think in the last 1 minute, I would like you all to just give us one key takeaway message, all the three panelists for the group. In the last 1 minute, this is a quick fire round.
Okay. I think this, so I'll start. I think that this is an exciting new technology, the different systems that come out. I think the main point here is that we potentially, as new data comes in and we get more information, have a new tool in our arsenal of fighting postpartum hemorrhage, still the #1 worldwide killer of women. Yeah,
Andy?
Oh, thank you. Yeah, I think the key point here is that the uterine suction or vacuum-induced hemorrhage control, whatever we call it, is a paradigm shift. It's going away from the positive pressure balloon pushing the uterus out to allowing the uterus to do its natural physiologic response. And I think that's what excites us so much about this technology.
Justice?
Thank you. I think the concept of suction to collapse the uterus is an intuitively attractive one. We need to push forward with research to be sure that it is something that really works in the clinical setting. And then once we are sure, we need to try and make sure that this technology is available as widely as possible. Thank you.
And I think just one more thing, which I feel is so crucial, because I'm really one for having task sharing. So in the last group, there was this question about can nurse midwives use this? And I think the response which you all gave was yes. So I think that the key takeaway is that this can be task shared and frontline health users can use it. Is that right? Is my understanding and takeaway right?
I think I answered that one, and if it's shown to be effective, it's a technically very, very, very simple thing to do. And there's absolutely no reason in my mind that midwives should not be able to do this. Of course, there may be regulatory issues, but from the practical life-saving point of view, there's no reason midwives should not be doing this.
Agree.
Thank you so much. And finally, I think what the participants has mentioned is that there's a great innovation. The price point will be key for the low resource setting. And we hope you all can bring it to that price point where we in the mountains of Nepal can afford it. So thank you so much, everyone. And thank you, participants, for this really interactive discussion. We've learned a lot from you. If there are any questions which are unanswered, we will definitely make sure to answer them and be able to circulate you. Thank you so much. Thank you, great panelists. It was, and Debbie, thank you.
Thank you very much, everyone.
Thank you, Kusum, and thanks to all the audience.
Yeah. So Alexa, now we leave and go back? Or what was the coffee or the happy hour? Where was it?
Yes, so you can all return to the plenary as well. So the link that's in the chat, you can just click on that if that's helpful.
Okay. Thank you so much, Mashallah, Andy, Justice. Oh my God, it was so great to be moderating this session and learning from all of you. Thank you so much.